Hello and welcome to the this month's edition of the Cancer Prevention and Wellness series, sponsored by the Cancer Survivors Park Alliance. I'm your host, Jeff Jaguar. Every month we try to introduce and review a subject with the intent of changing the way, hopefully positively, that we live with cancer. Today we have with us Dr. Laura Wang, who is with the academic line of the Department of OB/GYN at Prisma, obstetrics and gynecology. She is a specialist in vulvar pathology, dermatopathology. She is an immigrant from Taiwan, came here for high school and matriculated to Northwestern for undergrad and medical school, and then did her residency at the George Washington University Medical Center. She and her husband came to the upstate in early 2000s, and we're very happy to have her. Tonight we're talking about a subject of women's sexual health. It deals mainly with women's sexual health after a diagnosis and treatment of breast cancer or a GYN malignancy, but it really applies to treatment of any malignancies. And it needs to be stated up front that this is not a taboo subject, and it's something that you need to potentially discuss with your doctor. There are some expected side effects of your treatment. Some of those have a major effect on sexual health and libido, that you are not alone in these symptoms, and your doctors are well-versed in those symptoms. And the most important thing we want to get across is that there are, in the last 5 or 10 years, a large number of treatment options that we can offer for these symptoms. So, Dr. Wang, thanks for being here and for the presentation of a wonderful subject that we have little knowledge of, and we need more.
Thank you, Dr. Jaguar, for the wonderful.
Take it.
Sorry.
I'll let you take it from there.
Thank you, Dr. Jaguar, for that lovely introduction. Hello, everyone. I'm Dr. Laura Wang. I'm from the Department of Obstetrics and Gynecology at Prisma Health. And today we're here to discuss women's sexual health, to address questions you've always wanted to ask but are too afraid. In advance. Okay, didn't push hard enough. Okay. As you all know too well, cancer diagnosis and treatment are associated with many physical and psychological changes that can affect women's sexual health. Genital, urinary, and sexual concerns are often overlooked or not fully addressed. There are a few reasons for this. Number one, sexual issues may not be a patient's top concern during the initial diagnosis and treatment of cancer, as the focus and priority tends to be on overcoming the disease. It may become more of an issue only after treatment has begun and the changes have set in. There's also the issue of time constraint during your limited appointment time with your care team. And unless specifically raised by clinicians, women are often reluctant to mention their genital urinary concerns, and as a result, the topics are rarely discussed. To further complicate the matter, much controversy and uncertainty exist about treatment options, leading to confusion all around. These are the reasons that I'm here today, to answer questions you wanted to ask. So let's get started. Okay, the first question that we often run into is, how does sex change after my cancer diagnosis and treatment? Well, let's break this down into physical changes versus psychological changes. Okay, let's first tackle the physical changes. Nipple surgery and mastectomy both disrupt the nerve innervations or supplies, and therefore can decrease the excitement response derived from breast and nipple touching, and therefore affect sexual pleasure. By contrast, breast conservation surgery retain nipple and breast nerve supplies and preserve sensitivity, and therefore does not tend to affect sexual response. Hysterectomy can lead to vaginal shortening, and removal of ovaries means the loss of estrogen, which then lead to vaginal dryness and sexual pain. Radiation treatment to the chest can lead to increased sensitivity, pain, and tenderness to touch. Pelvic radiation can result in irreversible vaginal shortening and narrowing, as well as loss of elasticity or stretchiness. The psychological aspects of cancer treatment can be just as discouraging. As a woman's breasts are often a symbol of their femininity or her femininity, much as her uterus is a representation of her fertility. The loss of her breast or uterus could make a woman feel less feminine, less attractive, even less whole. And then there's the issue of anxiety and depression. The challenge of confronting one's mortality during cancer diagnosis and treatment can often make anxiety and depression worse, or even precipitate their new onset. And this could adversely impact sexual desire and intimacy. And to make matters worse, some medications used to treat anxiety and depression have sexual side effects. For example, some psychotropic medications, including some very common SSRIs and SNRIs and tricyclic antidepressants, are associated with adverse sexual side effects, including decreased libido and delayed orgasm. Okay. Another question that we often confront is, why do I want to have sex? This is also known as decreased libido. It is often multifactorial, caused by a combination of psychological factors such as anxiety, depression, life stressors, relationship issues, as well as physical factors, most commonly sexual pain. HSDD, or hypoactive sexual desire disorder, genital arousal disorder, orgasmic disorder, are also causes for decreased libido, but they're not as commonly associated with cancer diagnosis and treatment, and therefore are not within the scope of today's discussion. So how do we treat decreased libido? Well, we first start by addressing the underlying causes, whether that be anxiety and depression or sexual pain from atrophy. Also want to review potential medication side effects. Something to consider is using a clitoral stimulatory device such as vibrator to enhance sexual pleasure. There are also some medications that might be able to increase libido. Also, don't forget about counseling, especially if there's concerns about body image or relationship issues. Sorry, let me just make sure I'm on the right slide. Okay. So of the options for decreased libido, testosterone is one of the most prescribed, although its effectiveness is debatable. It can be administered through several routes, including as a skin gel or cream. It can be given as a pill or even as an implantable pellet. You have to be careful when you're using testosterone not to get too high of a dose, because too much testosterone can actually have undesirable side effects, including excessive hair growth, hair loss, acne, and oily skin. And by the way, there's not any good safety data about using testosterone in this fashion in patients with estrogen receptor positive breast cancers. Okay, so let's say that we're going to use testosterone. The goal is to try to dose it to achieve a normal premenopausal physiologic range, which means average blood level between 27 to 40 or so. This can be accomplished by using a patch, a skin patch. It can also be accomplished by using a cream or a gel, getting on average about 5 milligrams per day to start, and you can titrate up based on the response. Okay, so third question, which is probably our most common question, is why does sex hurt? What are the reasons that sex hurts? What are the treatments for them? Are these treatments safe to use after the cancer diagnosis? And will these treatments increase the chance that my cancer is going to come back? And also, will this ever get better? Okay. So let's start by talking about genital urinary syndrome of menopause. This is a mouthful, so we're going to just, from this point on, call it GSM. Or really just genital atrophy. Okay. So the female genital urinary tract is rich in estrogen receptors. In the vulva, which is the vaginal opening, in the vagina, urethra, bladder, and all the supporting structures. Estrogen decline can lead to atrophy of all of this tissue, which means thinning of all the skin down in the opening, in the vagina. It means thinning of the support tissue in the vagina and the loss of elasticity, so it's not as stretchy. It can lead to vaginal narrowing and shortening, and it can lead to the vaginal entrance getting smaller and tighter. So what does that look like in real life? So patients with GSM typically will complain of genital dryness, burning, irritation, itching. They might even present with some pussy-looking discharge. Sex oftentimes will become painful, and they might also have difficulty with arousal and orgasm. In addition to sexual problems, they might also encounter some urinary problems, including frequency, urgency, meaning having to go frequently and with very short notice. They might have pain during urination, burning during urination, incontinence, as well as recurrent UTIs. Okay. So GSM doesn't just affect breast cancer patients. It's seen in up to 40% of the general population, but much higher in breast cancer survivors, up to 75%. As mentioned earlier, as a result of estrogen deprivation. It can come from menopause, whether that's spontaneous or through surgery when ovaries are removed. It can also be seen after pregnancy, especially during lactation, and can be seen as a medication side effect with something like Depo-Provera, which is a contraception, Depo-Lupron, as well as in patients that are receiving adjuvant endocrine therapy. Okay. Adjuvant endocrine therapy is a treatment to counteract the stimulatory effect of your body's hormone in those that have hormone receptor positive cancers, especially breast cancer. Tamoxifen and aromatase inhibitors are probably the best known examples of adjuvant endocrine therapy. They can reduce the risk of breast cancer recurrence and death. And therefore, the majority of early estrogen receptor positive breast cancer patients will be offered adjuvant endocrine therapy for anywhere from 5 to 10 years. Now, these therapies result in estrogen deprivation, not just in the genital urinary tract, but throughout the body. So the side effects will include oftentimes hot flashes and night sweats, as well as atrophy symptoms. And these side effects are actually very similar to those that are experienced during natural menopause, but tend to be a little bit more severe. So how do you know if you have GSM? Well, for most patients, this diagnosis could be easily made through a physical examination. If the exam is uncertain, vaginal pH or looking at the discharge under the microscope could also be helpful. Okay. This is a picture of what a patient with GSM look like. So this is the vaginal opening, or what we call the vestibule. You notice that it's much more pale. It's lost the color, the pink color. The lips are much smaller. And the vaginal opening is much narrowed, making penetration much more difficult. This is a picture of a vagina with GSM. Vagina is pale. It's lost all the wrinkles. This is one place in your body where wrinkles are actually highly desired. There's really not a lot of discharge. And you see these red dots, which is actually a sign of tissue thinning and some inflammation. Here's to show you a slide of a patient's discharge that have GSM. So the larger round blue circles are the immature, not fully developed vaginal cells. You also see a lot of the smaller black dots. Those are all inflammatory cells. Okay. So what do we do if we have GSM diagnosis? How do we treat that? Well, there's a range of options to treat GSM. To start, especially for those with milder symptoms, lubricants and moisturizers may be a very good option. And if that doesn't work, or if you have more moderate to severe symptoms, hormones can be an option. Hormones ranging from estrogen, DHEA, and testosterone are all available for treatment of GSM. There's also a non-hormonal option that we'll talk about later. Okay, so let's start by talking about vaginal lubricants versus moisturizers. Lubricants sit on the skin surface, while moisturizers are absorbed by the skin. So the main difference between a lubricant and a moisturizer is how they're used and their intended purpose. So lubricant is intended for use during sex to increase the lubrication. It could be water-based, silicone, or even oil-based. Moisturizers are intended for regular use to replenish the vaginal moisture and relieve the discomfort from vaginal dryness. It can be applied up to 2 hours before sex, and it will last up to 3 days. For those with severe dryness, you might want to consider using the moisturizer every day for 2 weeks. And once the tissue is better, you can decrease it to 2-3 times a week to maintain. For best result, though, you might want to consider a combination approach. Use a vaginal moisturizer regularly, and then add the lubricant for sexual activity. And please be sure to choose products that are free of perfume and paraben in order to decrease the irritation and sensitivity. Okay. Here are some examples of lubricants. I've broken it into 3 categories: water-based, silicone-based, and oil-based. Most water-based lubricants have water, of course, and glycerin, and sometimes xanthan gum, which is a natural thickener to make it adhere a little bit better. Water-based lubricant tend to be the most commonly used. It's typically very safe to use with condoms and sex toys and doesn't cause much of a reaction. Having said that, silicone-based lubricants are much more effective than water-based lubricant for discomfort during sexual activity in postmenopausal patients with breast cancer. Problem with silicone-based lubricants, though, is that it can stain sheets and underwear, and they're also slippery on wet surfaces, so should not be used in the shower. Silicone-based lubricants can also damage silicone sex toys. Oil-based lubricants are less used, probably because they can be a little bit more irritating. Our vagina is not able to self-cleanse oil-based products, so they tend to linger around a little bit longer and therefore cause irritation and possibly contribute to infections.
Dr. Wang, are these all over the counter?
These are all over the counter.
And I hear of an ingredient, hyaluronic acid. Is
Yes.
that part of one of these?
Not yet. That's typically used more in moisturizers. And we're actually going to talk about that, I think, like 1 or 2 slides later.
Okay, great.
Okay. These are some examples of water-based lubricants that are easily obtained. K1 Astroglide you can usually get at just your local pharmacy. Slippery stuff is not as popular in this area. I know that our hospital pharmacy sells it, but it's easily obtainable through Amazon, of course, right? It's fairly inexpensive. It's very hypoallergenic and therefore very well tolerated. Okay, now let's spend a little bit of time on moisturizers. These are a little bit less known than lubricant, so I want to go over it in a little bit more detail. We're going to talk about 2 categories of moisturizers. The first category is those using polycarboxyl, namely Replens. Now, when you're going to go buy Replens, you got to be careful. Replens actually has a moisturizer and a lubricant. So figure out what it is you want and get the right product. So polycarboxyl-based vaginal moisturizer, or Replens, produces a moist film over the vaginal skin cells, and it will hydrate the vaginal tissue and improve the pH and the dryness and decrease sexual pain. They're fairly inexpensive and are pretty effective to treat mild dryness. And most drugstores actually carry this. The next 3 products that we're going to talk about all use hyaluronic acid, what Dr. Jagir just mentioned, as their active ingredient. They may not be as commonly accessible through local drugstores, but are very easily obtainable on the internet. Cost is a little bit higher, but the improvement in your vaginal tissue, I think, is quite worthwhile. The most popular one around here is probably Rubbery. at $62 a month for 10 applications. Now you can try to buy 3 month supplies. That will bring the price down to about $45 per month. Oopsie. Okay, this just to show you what these containers look like, so that when you're searching, it's easier to identify. Okay. How about for external comfort? Either separate than intercourse or after sex. Okay. That is when natural oils and balms can be very useful. Natural oils and balms can help to soothe the itching and irritation after sex. Some of the products that people like, vitamin E oil, coconut oil, or this other product called V Magic. You can order that online. V Magic is a plant-derived oil that can relieve vaginal dryness and irritation. Now, a lot of my patients actually prefer petroleum-based product, such as Aquaphor or Vaseline. And for external use, it's extremely safe. And it actually protects the skin, restores the barrier function by allowing the skin to heal from within. One caution about Aquaphor is that it contains lanolin products. So both for those that have sensitivity, probably want to steer clear of that. Okay, how about lidocaine? Could that be an option? Here's a study from 2015 where they looked at 46 patients with breast cancer and sexual pain. And what they found is that in these patients, consistent use of aqueous lidocaine help with discomfort at the vaginal opening before penetration. Okay, so let's say the moisturizers and lubricants are not quite enough. What else is there? Well, hormones have been consistently shown to be helpful. So let's move on to that. So how do they actually help with sexual pain? Let's start with the most common of the hormones that we use for this, which is estrogen. So how does the estrogen work? Estrogen helps to mature vaginal skin and improve the blood flow to the area in general. And as a result, the vaginal elasticity is improved, there's more lubrication, and there's better sensation. And in actuality, it will improve sexual desire, arousal, coital satisfaction, and orgasm. And it can also be helpful to reduce UTI incidence and make it less frequent. Vaginal estrogen preparation is the preferred treatment for those with isolated, moderate to severe atrophic symptoms in the general healthy female population. 3 products are commonly available in the United States. There's a vaginal cream. Brands include Premarin or Estrase. There's a tablet. There's also a vaginal ring. Now, a word of caution about the vaginal ring. Even though it delivers the lowest estrogen dose, which is desirable for a lot of patients, it's the size of a very small donut. And patients with narrow introitus are literally not going to be able to tolerate the insertion of this vaginal ring unless they've already been using cream or something else to reverse the atrophic changes. So as good as estrogen is at reversing the changes of atrophy and addressing the associated symptoms, a lot of concerns still exist about its safety, especially in patients with estrogen receptor positive breast cancers. Now, there is limited data from both observational studies and larger trials that have been somewhat reassuring in this subset of patients. And we're going to look at that just very briefly. Here's a study that came out in 2010. It was a rather short study of 12 weeks, looking at 18 patients with breast cancer. They were giving low-dose vaginal estrogen versus a moisturizer. What they found is that both low doses of vaginal estrogen were more effective for relieving atrophic symptoms compared to non-hormonal moisturizers, which only provided some temporary relief. They also saw that there was very minimal increase of estrogen level in the bloodstream in the patients that are using the estrogen product. More recently, a much larger study came out of Denmark in 2022. They looked at using vaginal estrogen after early breast cancer compared to systemic estrogen, orally ingested estrogen. This study involved over 8,000 patients. These patients were followed from anywhere from 10 to 15 years. And what they found was that in postmenopausal patients with these early stage estrogen receptor positive breast cancers, neither treatment was associated with a higher risk of cancer coming back or higher chance of dying from the cancer. Having said that, there was a small subset of patients that were using the vaginal estrogen while they were on aromatase inhibitors. And these patients had a slightly higher risk of cancer coming back, although without increased mortality. This is the most recent study that we have on using vaginal estrogen in breast cancer survivors. It was published in January of this year. They looked at over 4,900 patients, so close to 50,000 patients. I had to think there for a minute. They follow these patients for average of 10 to 20 years. And what they found was that there was no evidence of increased breast cancer specific death in the patients who are using vaginal estrogen compared to patients who did not use any hormones. Okay. So what do we know about estrogen? Well, despite all the somewhat reassuring studies, we still don't have very definitive evidence about how this estrogen therapy will affect breast cancer prognosis. Therefore, non-hormonal options should always be considered as first-line treatment for these patients. Having said that, if the atrophic symptoms persist and the quality of life is seriously impaired, then individual women with low risk for tumor occurrence may wish to discuss the option of estrogen therapy with their oncologist and their gynecologist. How about DHEA? Okay. DHEA is another hormone. It's a precursor for all the male hormones in our bodies. When put in the vagina, DHEA is converted into different types of male hormones and different kind of estrogen. And studies have shown that intravaginal DHEA actually help to mature the vaginal cells and improve elasticity and dryness and decrease sexual pain, and therefore improve desire and interest, arousal, orgasm. So FDA has approved one DHEA product. It's called Intrarosa. The approval, though, is only for healthy postmenopausal women with moderate to severe sexual pain. There's no safety data in using this in breast cancer patients, and therefore cannot be routinely recommended without consulting your oncologist. How about testosterone? So topical testosterone has been tried in breast cancer patients. This is a study, rather small, 21 patients using testosterone for only 4 weeks. What they were able to show is that vaginal testosterone use was associated with improved signs and symptoms of atrophy. There was no increase in blood levels of estrogen or testosterone. However, there's no long-term data. This is another study looking at testosterone use in breast cancer patients using aromatase inhibitor. And what they were able to find is that the use of testosterone vaginal cream applied daily for 4 weeks improves sexual health overall in these patients. Okay, so to summarize what we know about testosterone, in patients that are using an aromatase inhibitor, it should block the conversion of different kind of male hormones, including testosterone, into estrogen. So it could possibly be an alternative to vaginal estrogen to treat patients with atrophy symptoms on aromatase inhibitor. The data on the effects of increased serum levels of estrogen, though, is lacking. And there's just not been a lot of safety studies to look at how this is going to affect women with a cancer diagnosis and their chance of recurrence or survival. Therefore, testosterone and other androgens cannot be routinely recommended in women with a history of breast cancer without consultation with your doctors. Okay, last but not least is this newer line of product called selected estrogen receptor modulator. There's only one that's approved in the United States for the treatment of sexual pain, and that is ospermifene or Osphena. It has been shown to improve vaginal wall thickness, reverse atrophy, and decrease sexual pain. It can also increase hot flashes and night sweats, by the way. Now, this product has not been studied in women with or at risk for breast cancer. There's also no safety data on using Osphena and other therapies for breast cancer. So the FDA does not currently recommend its use in women with or at risk for breast cancer. Okay, how about laser? We all hear about laser. It's very popular in social media. The one that's most commonly mentioned is called Mona Lisa, which is a fractional carbon dioxide laser. So what it does is it causes micro injury to the vaginal tissue. And the tissue, in order to try to recover from the injury, will have increased collagen production and elastic fiber production. And the theory is that by having this remodeling happening, that vaginal dryness, burning, itching, and sexual pain can be improved. And there's been some small limited studies that have shown exactly that. But all these studies are very small in numbers, are very short term, and the efficacy and safety long term is not clear, and there's no published data on using this in breast cancer patients. Also want to mention cost. It's a rather expensive approach, typically a little over $3,000, and it is not covered by the medical insurance. Okay, so now that we finished talking about genital urinary syndrome, menopause or atrophy, as it relates to sexual pain. Let's move on to the next cause, which is hypertonic pelvic floor dysfunction. It's typically a male adaptive reaction to other causes of sexual pain. So patient might start having sexual pain because of atrophy. And as a result, they tighten their vaginal muscles, which makes the vaginal opening smaller and much more painful to penetrate. So what can we do about this? The most effective treatment for hypertonic pelvic floor dysfunction is pelvic floor physical therapy by a qualified, well-trained physical therapist, involving internal manual releases where they go into the vagina and manually massage these pelvic muscles to try to release these knots. Vaginal dilators can also be used to help patient get used to the sensation of penetration. They may also use biofeedback to help patients identify the muscles that they need to concentrate on relaxing. Now, how about Kegel exercises? A lot of patients will ask, can I just do Kegel exercises at home by myself? It's a lot cheaper, it's a lot more convenient. Well, the problem with Kegel exercises is that most patients practicing Kegel exercises actually are tightening their pelvic vaginal muscles as opposed to relaxing them. So that's actually counterproductive and can make sexual pain worse. Now, some patients also would use benzodiazepines, such as Valium, in the vagina or rectum to try to relax the sexual muscles. But these are usually used in conjunction with physical therapy. And if all else fails, Botox therapy can be considered. Obviously, much more invasive and much more expensive. Here's an example of vaginal dilators. These come in various sizes that you could start small and then work your way up to the size of your partner. These are especially helpful in patients that have vaginal shortening or narrowing after vaginal surgery or after pelvic radiation treatment. Okay. This is called an O-nut. It's helpful for those that have a shortened vagina. It's placed over the partner's penis to be able to control or limit the depth of penetration into the vagina. I usually recommend that the patient be the one to control the O-nut by holding on to it during penetration. Okay, so that's the end of my talk. So what is the message that I want you to get out of this? Well, there are several things. Number one, I want you to think about the side effects of cancer treatment and how it might negatively impact quality of life, including sexuality and intimacy. Initiating the discussion about sexual side effects early on in cancer treatment will help empower patients to be more willing to discuss future issues that they may experience. And it's also important to recognize that the earlier that you intervene, the more likely any of these options are going to be effective. Now, there's not a best treatment approach for everyone. The treatment that you should choose should be the ones designed to fit your individual needs, whether that be lubricants and moisturizers in those with milder symptoms, liquid lidocaine to help ease the pain at penetration, ultra low dose vaginal estrogen. Also want to consider counseling and sex therapy, either alone or couple-based. Pelvic floor physical therapy may be very helpful for those with hypertonic pelvic floor contractions. Vaginal devices such as dilators and vibrators might be helpful in stretching the vagina and to enhance sexual pleasure. Also, make sure that treatment of underlying depression and anxiety is carried out. Okay. So while limited evidence on the benefit of low or ultra low dose vaginal estrogen is promising, we really need a lot more safety data. For example, it's still inconclusive whether systemic absorption after topical use of the estrogen may increase the risk of breast cancer recurrence and death. After discussing the potential risks, if vaginal estrogens are indicated and prescribed, try to stick with the lowest possible dose. And only after risk assessment by your oncologist and obtaining informed consent from the patient. That is my last slide.
Well, that was very complete and excellent and concise, actually. So I know that there are people that will be listening to this that will have questions. Let me try to anticipate some of those. I think the major message that I would want to get across is that I know you're going to see your GYN oncologist or your medical oncologist or your surgeon, and you see that they have limited amount of time to see you during your visit, and they're trying to treat your cancer, and you just don't want to bother them with these side effects that you consider, maybe, too selfish to mention. And I just want you to know that we are kind of used to fielding these questions. More and more, we are having female physicians that become oncologists, and they kind of gravitate to the subspecialty of being breast oncologist or breast cancer oncologist or GYN oncologist. So it may be easier to talk to somebody of the same sex about these issues. But I think most of us have a aptitude for fielding these questions and figuring out if we can't answer them or prescribe something, or there are places for us to refer. I was going to ask you, Dr. Wang, about pelvic physical therapy. I know when I was practicing, there weren't a lot of pelvic physical therapy options within the hospital. Is that changed?
Fortunately, that has. The discipline has become much more recognized. We are actually seeing the surge of interest both in patients and in providers. And I would say over the last 20 years that I've been in the upstate, the number of people that are qualified to provide this therapy has more than quadrupled. Still not quite enough to meet the needs of all of our patients, but that trend is encouraging. One word about accessing these physical therapists, though, is that not all pelvic floor physical therapists are trained to treat sexual pain. So there is actually 3 levels of certification for pelvic floor physical therapists. The first level are trained to treat incontinence. It's only level 3 providers that have been trained to treat sexual pain.
Okay.
So it is very important that you do your investigation before spending all your time and effort and money to go through somebody who may not be able to get you the result that you need.
Awesome. One of the things that we haven't talked about at all is that there is another side of the sexual conversation, and that is the partner. And we've talked a lot about women's sexual health. We haven't talked anything about men's sexual health, and it's an issue. from the standpoint that a very common male cancer is prostate cancer, and it is driven by androgen. And so the therapy is to diminish androgen supply. So there are some things, and one of the things that has been a common uh, educational tool within the survivorship community is that of lifestyle medicine. And there is evidence that what you eat can also affect your sexual performance. So a more whole food, plant-based diet can improve sexual function. Physical activity, exercise, can help in this regard as well. Getting plenty of sleep, getting 7 to 8 hours of good quality sleep each night, maintaining your social contacts and your relationships. And then it's clear, and I know you tell your patients this, cigarette smoking and any more cannabis smoking is not good for the tissues. And I think the same holds true for alcohol as well. So there are some things that one can do in the overall away from cancer lifestyle that can make a difference about how some of these treatments may work, because you're kind of helping them halfway to be successful.
Absolutely agree, especially with the smoking. It can decrease the blood supply by impairing the little blood vessels in your body, including in the genital area. So smokers tend to have impaired blood flow to the area and therefore more atrophy symptoms.
Well, again, on behalf of everybody that puts on this program, the Cancer Survivors Park Alliance, I thank you for your obvious effort in putting together this talk and your great presentation. And we thank you for your time and effort.
And thank you for the opportunity to discuss this very important subject. And everybody have a great weekend.
Thank you. We will be back with you next month, and the topic will be deeper than the surface, skin cancer prevention and awareness. And as per my usual, I leave you with a couple of quotes. And these are from Carl Jung, who is a Swiss psychologist. You are what you do, not what you say you'll do. And another one, we deem those happy who from experience of life have learned to bear its ills without being overcome by them. So, Dr. Wang, thank you. And as per Dr. Wang said, have a great weekend, everybody.
Thank you, everyone.